Welcome to Baptist Medical News Network. I'm Rhonda McRae. Thank you so much for joining us for our webcast today. Today our topic is Mom Has Atrial Fibrillation. And so to help us with this very important topic today, we have with us Dr. Mike Bensler. Dr. Bensler, thank you for joining us today.
Oh, you bet.
And let's jump right in. Dr. Bensler is a cardiac electrophysiologist, which is a cardiac subspecialty dealing with atrial fibrillation. So before we start talking about atrial fibrillation, Dr. Bensler, tell us about your subspecialty and how it relates to atrial fibrillation.
Great question. Well, cardiac electrophysiologist is someone who actually takes care of people with abnormal heart rhythms. And atrial fibrillation is a very common abnormal heart rhythm that affects probably close to 1% of the general population in the United States, so millions of Americans. Many primary care providers or primary care physicians and general cardiologists treat patients with atrial fibrillation every day. Usually they offer these patients medications or have them do lifestyle changes to treat their atrial fibrillation. But a cardiac electrophysiologist is someone who can actually offer advanced therapies for atrial fibrillation, such as cardiac ablative therapies.
Okay, great. All right, so we're talking about Mom Has Atrial Fibrillation, but before we get to that point, maybe we should define it a little bit. So, Dr. Bensler, tell us exactly what is atrial fibrillation.
Well, atrial fibrillation is a disease of the upper chambers of the heart, or the atrium, and it's an abnormal heart rhythm. And it's really characterized by rapid, disorganized electrical firing of the atria, which actually manifests itself as an irregular heart rate, which can also cause significant symptoms in patients who have atrial fibrillation. There are certain risk factors that people can have that can lead to atrial fibrillation: people with high blood pressure, congestive heart failure, coronary artery disease, and patients with these structural abnormalities of their heart are more likely to have atrial fibrillation. Now, probably up to 20 to 25% of patients actually don't have any structural heart disease or any systemic illnesses such as thyroid disease or obstructive sleep apnea that can lead to atrial fibrillation. Some people also can have atrial fibrillation from excessive caffeine or excessive alcohol intake. So you really need to figure out what the underlying cause is, if there is any, for atrial fibrillation in your initial assessment. But atrial fibrillation, probably the worst thing about it is that because there's a uncoordinated contraction of the top chambers of the heart, or the atria, when these atria don't contract in synchronous fashion, little blood clots can form on the sides of the heart. And if those blood clots break loose, they can actually go to the patient's brain, they can go to other organs and cause strokes and other damage. So that's really what you're worried about with atrial fibrillation. Well,
that was kind of leading into my another question, is how serious is it?
Well, atrial fibrillation, unlike an acute myocardial infarction or a heart attack, is a little bit different. If patients have minutes to just a couple hours of atrial fibrillation, the consequences aren't as serious as somebody who's having a heart attack who needs rapid evaluation and treatment for their heart attack. However, if you have atrial fibrillation for a lengthier period of time, hours to days and sometimes years, if you're in permanent or persistent atrial fibrillation, there is an increased risk of stroke, an increased risk of death from cardiovascular causes, and an increased risk of heart failure. And particularly, the increased risk of stroke is very concerning. And again, as we just mentioned before, patients who have diabetes, congestive heart failure, or high blood pressure are at a particularly increased risk of stroke as well. Patients who have rheumatic heart disease from rheumatic fever as a child, these patients can have a yearly stroke risk of approximately 10% a year. Patients with those other risk factors that we just discussed, usually their stroke risk is on the order of around 5 to 6% per year. But probably the most serious consequence of atrial fibrillation is a devastating stroke, and that's really what you're trying to prevent in both the short and the long term.
So the danger of atrial fibrillation going untreated is extremely or much higher risk for stroke.
Absolutely. And we didn't talk about heart failure as much, but if you look at the heart failure trials over the last 20 years or so, it's well known that patients with both a combination of congestive heart failure and atrial fibrillation do much worse and have an increased mortality from cardiovascular causes compared to patients with congestive heart failure alone. And even patients who develop the beginnings of congestive heart failure before they develop full-fledged heart failure, can have significant symptoms that can really impair their quality of life.
Mm-hmm. So, talking about symptoms, could a person have atrial fibrillation and not know it? What are the symptoms?
It's definitely possible, and probably the most common symptoms of patients who have symptoms with their atrial fibrillation include shortness of breath, chest discomfort, a rapid pounding sensation in their chest or palpitations, anxiety, fatigue, lightheadedness, and an overall lack of energy. However, probably again, 25 to 30% of patients who are in atrial fibrillation will be completely asymptomatic and completely unaware that their heart is in atrial fibrillation. And the reason why this is an extremely important point is that both asymptomatic and symptomatic individuals with atrial fibrillation are at the exact same stroke risk. And so these patients really need to see their doctor, even if they're not having any symptoms, because the consequences of atrial fibrillation are the same whether or not you have symptoms.
So that might be a reminder for everyone of the importance for an annual physical with their primary care physician.
Absolutely.
You can't have these illnesses without symptoms, so see your doctor. All right, so we've talked about the risks and symptoms or not, but let's get into treatment. What are some treatment options for a person with a diagnosis of atrial fibrillation?
Well, the most important thing for treatment right off the bat is really modifying your stroke risk. So again, we've talked about this several times. The risk factors for atrial fibrillation and the risk factors for developing a stroke with atrial fibrillation consist of high blood pressure, congestive heart failure, age over 75 years, high diabetes, and if they've had a previous history of stroke, they're at a very high risk of having a second stroke from atrial fibrillation. Now, you have to really assess how many of these risk factors a patient with atrial fibrillation has to determine what type of therapy you give to treat their or to reduce the risk of stroke. Most people with one or none of these risk factors are fine taking aspirin as antithrombotic therapy to reduce the risk of stroke. However, if any of these patients have two or more of the risk factors we talked about or have rheumatic mitral valve disease, they really should be on warfarin, or the brand name for that is Coumadin. They should be on warfarin anticoagulation to significantly reduce the risk of stroke. And that's, again, the most important thing for treatment of risk reduction for stroke with atrial fibrillation.
And those are blood thinners?
Those are all blood thinners, aspirin and warfarin. Now, if the heart rate is too fast, there are multiple things that you can do. Probably the first thing that we do in our stepwise approach to treating atrial fibrillation is give patients what we call rate control agents. These are medications to slow the heart rate closer to a normal range. Some people with atrial fibrillation can have a very rapid heart rate, and that can make them feel significantly symptomatic. And so we'll first usually give rate control agents to slow down the rhythm. Other medications that we can give are antiarrhythmic medications. Antiarrhythmic medications usually have a lot of toxic side effects and actually need to be monitored pretty closely by the patient's either general cardiologist or cardiac electrophysiologist. But these are medications that can help keep the patient in a normal rhythm in addition to the rate control agents. Now, more advanced therapies that we are able to offer patients with atrial fibrillation, for instance, you can actually electrically shock or cardiovert the patient out of atrial fibrillation into a regular rhythm. Now, when we do this, we usually bring the patient to the hospital, we put them to sleep, and we actually do a cardioversion under intense cardiac monitoring in the hospital. So this is not something we take lightly. Sometimes people after a successful cardioversion can stay in a normal rhythm for days, months, or rarely even years. So we do like to offer that to some of our patients. But probably the most definitive therapy that we offer is cardiac ablation procedures. Ablation procedures are minimally invasive catheter-based therapies that we do in the electrophysiology laboratory. Usually the procedure takes about 3 to 6 hours in general. This is a procedure where we take these catheters and advance them into the heart under fluoroscopic guidance, and we actually deliver radiofrequency energy to electrically isolate the triggers in the heart that can lead a patient's heart to go into atrial fibrillation. And this is really a wonderful therapy because it's minimally invasive, it involves no incisions, no cuts, and if there are no complications with the procedure, the patient only needs to be observed overnight and then can go home the next day.
And after this procedure, did the patients ordinarily need to remain on the the blood thinning medications?
They still do need to take usually warfarin anticoagulation for anywhere between 3 to 6 months after the procedure. And some of the medications you can actually stop if the ablation procedure is successful. We usually try to get patients off of antiarrhythmic agents 3 to 6 months if they're not having a lot of atrial fibrillation after the procedure. We do event monitors and other electrocardiograms to see if they're having a lot of AFib after the procedure's done.
But the procedure generally is very successful, or what is the...
Again, it really depends on the patient's risk factors, it depends on the patient's age. We can talk about kind of who's a good candidate for various types of treatments. Elderly patients or patients with several of those risk factors, such as high blood pressure, congestive heart failure, diabetes, the success rate for ablation procedures isn't as good as it is for patients without those risk factors. We usually opt to treat those patients a little bit more conservatively with just antithrombotic therapy and either rate control agents or antiarrhythmic medications. Now, patients that are very motivated to reduce their own risk factors, so a patient with high blood pressure who's willing to reduce their salt intake to help get better control of their blood pressure, that's the type of patients that is going to benefit from an ablation more so than someone who's not as motivated. Somebody who might be slightly overweight or obese who's trying diet and exercise to lose weight, they're going to benefit more from an ablation as well. Somebody with obstructive sleep apnea who's getting seen by a lung specialist and having their sleep apnea treated, they're also going to benefit. People that are willing to reduce their caffeine and their alcohol intake, they're going to benefit. People with heart failure who are taking their medications as prescribed, they're also going to benefit. So if you have a very motivated patient that's willing to modify their own risk factors, then as an electrophysiologist, you're probably going to be more likely to be aggressive with ablation therapy to treat their atrial fibrillation.
Mm-hmm. It's good to know that there are so many things that the patients can do to affect their own health in this area.
Absolutely.
I guess that's true for many things related to heart disease. So we've kind of talked about who's a good candidate for the ablation, and you hinted at those would be more the ones who are going to modify their own risk factors. Yes. So the medication route would be for those who are maybe not quite so willing to make those lifestyle changes.
Absolutely, and you have to remember that ablation procedures are not risk-free. There are significant complications that can occur from the ablation. So we like to really sit down and go over all those risks with the patient in the office, and some of those patients feel that some of the risks might outweigh the benefits of the procedure. And if you're a very high-risk patient that might have a higher risk of complications, you may opt for a more conservative treatment strategy. Okay. So that is something that we have to take into consideration.
All right, so now let's talk to the people who maybe we've got somebody who has a parent who already has a diagnosis of atrial fibrillation and maybe is on medications, maybe has had ablation. What sort, as you know, that person may have an adult child who's helping them watch their health. What do you need to be looking for? What might be some clues maybe that it's time to go back to the doctor, or maybe this isn't as controlled as it should be? What should both of them be looking for? Okay,
we can talk about those symptoms, but again, the thing that I want to impress upon everyone is the most important thing that you can do is really make sure you're taking your antithrombotic therapy, because really the major morbidity associated with atrial fibrillation that we're trying to prevent is a stroke.
Okay.
And so these patients really need to make sure they're getting their PT-INR or their pro time, their warfarin blood thinning levels checked as scheduled by their doctor, at least once a week or once every couple of weeks. And if they're not on warfarin, they need to make sure they're taking their aspirin on a daily basis. And so that's probably the most important thing, regardless of whether or not they're having symptoms or not. Now, if the patient does have atrial fibrillation that's varying between symptomatic versus asymptomatic, and you think that they might be developing worsening atrial fibrillation, some of the symptoms that you should be looking at is the patient having difficulty with breathing while they're lying flat? Are they having increased swelling in their legs? Are they having decreased exercise tolerance? Their energy level is just not up as much. Sometimes patients, if they feel their pulse, they can tell that their heart is beating rapidly and irregularly, but sometimes patients really can't tell. And so if that's the case and you have a family member who has atrial fibrillation, who's having these symptoms of shortness of breath or more shortness of breath laying flat, and you don't really know what's going on, you need to just bring the patient to see their doctor.
Okay.
An electrocardiogram is easily obtainable in pretty much all physicians' offices. It can help you diagnose atrial fibrillation and also tell you how fast the heart rate's going as well. So if there's ever any doubt as to how your family member is doing, if they have atrial fibrillation and they have any of these symptoms that we just talked about, just have them call their physician or really go see their physician.
Okay, so 2 kind of points to remember if you're helping somebody. Take your medicines as prescribed.
Yes.
Get your blood levels checked on schedule.
Yes.
And the symptoms to watch for: shortness of breath when you're lying down, maybe a little more unusually fatigued.
Yes.
Okay.
Absolutely. And just overall lack of energy and not feeling as well as they were if they had better controlled atrial fibrillation.
And in that case, it's see your doctor.
Yes.
Okay.
Absolutely.
Great. Well, Dr. Bensler, thank you so much for this great information on atrial fibrillation. It's a common problem, but it's good to know that there are so many things that can be done to help these patients. And I do want to let everybody watching the webcast today know that we have on staff a cardiac electrophysiologist like Dr. Bensler. So if you don't have a physician, you can call our Baptist Health Line for a free physician referral. You can do that online or at www.mbhs.org, or you can call our Baptist Health Line at 601-948-6262 or toll free 1-800-948-6262, and they can help you make that referral, make that contact with our cardiac electrophysiologists here on staff at Baptist. And we hope that you'll tune in for our future webcasts. And again, Dr. Bensler, thank you so much for joining us here today, and we hope to see you again soon.